Hello, I'm Dr. Todd Telemeco, the Dean for the College of Health Sciences at the University of North Carolina at Pembroke. Welcome to the Distinguished Speaker Series, our virtual version. Before I introduce our special guest, though, I want to thank the staff of the Campus Engagement and Leadership Office. They are co-sponsors for this Health Talk special event, and we're happy to be partnering with them each year to bring in a speaker of this caliber at the university. I'm also happy to announce that the College of Health Sciences will begin to develop these health talks throughout the next academic year as well to keep this theme moving forward. Through the years, the Campus of Engagement and Leadership has hosted numerous dynamic speakers, including Spike Lee, Aaron Brockovich, Bill Nye, the Science Guy, Deborah Norville, Maya Angelou, Cornel West, Wes Studi, just to name a few. And tonight's guest is no less dynamic. We believe there's actually never been a better time on campus to have our guest speaker tonight around COVID-19. Tonight's guest is the Director for the Center for Infectious Disease Research and Policy, or CIDRAP for short. He's a distinguished teaching professor in the Division Technological Leadership Institute, the College of Science and Engineering, and an adjunct professor in the medical school, all at the University of Minnesota. He's a very busy guy. In November of 2020, our guest was appointed to President Joe Biden's 13-member transition COVID-19 advisory board. And from June 2018 through May 2019, he served as the science envoy for the health security on behalf of the U.S. Department of State. He is the author of the New York Times bestselling book, Deadliest Enemy, Our War Against Killer Germs, in which he not only details the most pressing infectious diseases threats of our day, but lays out a 9-point strategy on how to address them while preventing a global flu pandemic at the top of the list. It's my honor to introduce you to our special guest tonight, Dr. Michael Osterholm. Welcome to the Health Talk special event.
Thank you very much, Todd. It's a real honor to be with you. I appreciate it.
We're really looking forward to digging into this pandemic and really hopefully dispelling some of the myths around the vaccine itself right now. The College of Health Sciences has been really engaged in the community of going out and helping to administer some vaccines to rural community members. And so while we've been out in that community, we've heard a lot of rumors out there and myths that need to be dispelled. So I think the first thing I'd like you to do with your expertise is, if you could, we now have 3 different vaccines on. Just spend a few moments talking about the similarities and differences about each of the vaccines. That might help us when we're out and about in the community.
Yeah. Well, first of all, let me just say the fact that we have vaccines a year into this pandemic is nothing short of a modern medical miracle. It really is kind of a combination of Manhattan Project, as well as now the dissemination of the vaccine in the community, kind of a Marshall Plan. When the pandemic was first recognized in January of 2020, at that point, we knew it was a coronavirus. We knew that coronavirus research had given us some evidence about how a vaccine might work, in particular this thing called the spike protein, which is on the outside of the virus that's really critical for attaching to a human cell and then getting inside the human cell. And there was already evidence that if we could mount a response against the spike protein, in other words, develop an immune response to it, we might be able to block that virus from entering the cell. And so lo and behold, that was kind of the simple part in a way of identifying the spike protein and how do we elicit an antibody as well as hopefully some T cell or cellular immunity response. And then everyone went to work. Within the United States, as you know, there was the formation of what was called Operation Warp Speed. Now, I think we did a few things in the U.S. government that were simply remarkable, and we did a few things that were like, why did we do that? On the remarkable side was there was not one moment of safety cuts put into place, meaning that anything was reduced in terms of overall evaluation of safety. But historically, what we've done when we've made a vaccine and brought it forward, it would take years to do. And the reason for that is we do step 1, get the results done, look at them, and then go to step 2. And then we do the studies or the work that we needed to be done, get that done, look at it, evaluate it, and then move to step 3, so and so. Rather than do that with this particular virus in order to get it done as quickly as possible, all the steps were done simultaneously, so that, in fact, if in the investment to do everything from the very most basic lab research to actually how to formulate the vaccine, how to make the vaccine, how to do the studies to evaluate the effectiveness of the vaccine, how to look at safety issues, were all done at the same time. And had any one of those steps failed, all the money that had been invested in everything after that would have been lost. So it was really more about putting money at risk, never putting people's lives or the safety of the vaccine at risk. And it worked. It worked because simultaneously all the different steps came together, all the right answers came together. And so when the vaccines went to the FDA for evaluation, everything was there that we needed to do to evaluate the vaccines. The first two vaccines on the market and the ones that surely have received the most attention in this country are the 2-dose Moderna and Pfizer vaccines. Those are both vaccines that basically rely on what we call mRNA technology. This is basically a kind of vaccine where the antigen, in this case the spike protein, is delivered via basically material to allow the spike protein to get inside a human cell and then it be expressed on the outside. So the genetic material for the spike protein gets inside the cell, not inside the nucleus, doesn't ever interact with the genetic material of the host. And then you basically grow the antigen yourself, to which the body then makes the immune response, and that's very short-lived, but it surely is a way to enhance your immune response. And this mRNA technology has actually been used for more than 20 years in cancer vaccine research. We've been involved with it working on things like influenza vaccines, cytomegalovirus virus. So it was not a new technology, but it was really new in the sense of such a broad-based application. Then one additional vaccine, the Johnson & Johnson vaccine, which was made out of an adenovirus, a type of virus that we encounter, and that was the carrier to get the material into the human cell so that we could again express basically the antibody against the spike protein. And that too is not new technology in that we've been working with adeno vaccines. In fact, that's a derivation of this is what we're using right now for vaccines for Ebola virus in Africa that have been highly, highly successful and their safety well tested. So, but the problem we had with these vaccines is because they appeared to be new and novel, they appeared to come under the auspices of Operation Warp Speed. They had a sense that the military was involved, so what does that mean? There was even suggestions in November or late October that the vaccines may have been influenced by some political decisions, so a political thumb put on the scale to get them licensed or not, which wasn't true. We had military individuals who were out front on it, being recognized for their work to help the logistics on this. And then on top of it, we had this new technology, and suddenly we just put it out there in front of people's doors and said, here it is. And we did a terrible job of explaining these vaccines to the public. You know, many very legitimate questions came up about, well, wait a minute. Is this injecting genetic material into me? What will this do to me? And there were sincere concerns about that. Was the safety compromised? How do you know it's safe? What do you know about it? And is it safe to take if I'm a pregnant woman, etc.? And so what's happened over the course of the now, millions of doses that have been given, we do understand the safety issues around it. Now, there's another vaccine, the AstraZeneca vaccine, which is also in the adenovirus family vaccine, which has received a lot of attention lately because of the possibility of causing blood clots. And it appears that this may actually be a real finding. It's a very, very rare finding, and one that the World Health Organization has said, look at the chances of this happening are so low relative to the chances of you getting COVID and having a serious illness and dying. Get the vaccine. And so you're going to hear more about that coming out, but just know this is not different than anything else. If we actually took the warning label for aspirin as it is applied, we would never use aspirin because of the potential for the negative health impacts that it can have in a very rare situation. So I think you're going to continue to see the AstraZeneca vaccine continue to be used. Let me just reassure the public that these vaccines have had a stellar safety record to date. particularly as we've used the Moderna and the Pfizer vaccines in the United States. And we know that they work anywhere from 90 to 95% of the time. After 2 doses, we even know they work after 1 dose up to 80% of the time or more against preventing infection. This was beyond our wildest dreams. I can tell you back in June of last year, there were many of us saying, boy, if this vaccine even works 50% of the time, won't that be great? But in fact, to see it work at a high level that it does is remarkable. The last point I'd make is that the immune protection from this vaccine is something we don't know yet how long it'll last. It may very well be that it could last for months to years. We just don't know. So we'll be following that very carefully. We have data now for 6 months after the vaccinations took place and still find very strong immune protection with regard to the vaccine. So we're going to have to follow that over time. The second thing is we're not sure what it will do against what we call variants. There are certain mutated viruses in the SARS-CoV-2 family, the group that causes COVID-19, that actually very well may have the ability to evade immune protection from either the vaccine and or natural infection. Now, when I say evade protection, this isn't just somehow it doesn't work at all, but it may reduce the protection level. And initial studies done with these vaccines would suggest where these variants have developed, one's called P1 that we first saw in Brazil, another one B135 is one that we saw in South Africa, and then of course B117, which is one we're seeing right now in the United States, originated likely in the UK, is not one that the vaccine has an impact on or it impacts negatively, but in fact the first two are. So all I can say right now is the vaccines, as we see them working against the virus strains in the United States, are very, very protective. And I can't urge you more strongly than tonight to beg you to get vaccinated if you haven't been. Remember, this is a vaccine that can not only save your life, but the life of your loved ones around you. And I can just say with absolute certainty, no one wants to be the person to die 3 days before they were scheduled to get their first COVID shot.
So let me ask you this, because what's an adenovirus? Because that word virus is still attached to it. Is it a safer type virus? What type of virus is it?
It's not actually even a live virus as such like that, so you don't have to worry about that part. It's not going to cause an infection in you with that. Okay.
And the second thing I'm going to ask you about is we often get asked, how is vaccine effectiveness determined? How's the data gathered, and how is getting the vaccine help us to continue that effort?
Well, there are two terms, efficacy and effectiveness, and they virtually are synonymous with some caveats. Efficacy is when you do a study where you randomize half the people to get vaccine and half the people to get a placebo. And no one knows who got what except for the people conducting the trial. And that's all blinded to the investigators. It's all blinded to the individuals. And then you follow them over time and you see what happens. In fact, you not only follow them for clinical disease, but you may take samples from them from time to time to see if they're asymptomatically infected in their throats, in their noses. You will also take blood samples to look and see what the immune response is, and you take them from both the people who got the placebo and the vaccine so you don't give away the code. And then there's a data monitoring board which follows this. And every time there's an event, someone gets sick, do they have COVID or not, that is all recorded by the data monitoring board. They also look for any safety signal. Is there something that might suggest that this is a problem that we want to delay or even stop the trial? And so they do both. And in the case of these vaccines, they went through very detailed, comprehensive efficacy studies to give us the data we have. Effectiveness studies are once it's in the market, once it's being used, then we can follow up with people. And by comparing people who are vaccinated, who are not vaccinated, and look to see what the difference in rate of disease is, and adjusted for by your ages and all these things, we can actually come up with another measure that says, in real hand and in real life experience, what does this vaccine do? Not under the quality controlled aspects of a clinical trial. And virtually so far, all the data supports that the effectiveness and efficacy are virtually the same. So this vaccine is operating very, very well right now. And we continue to monitor these studies all the time. One of the areas we're looking at right now is the possibility that variants, the ones I just talked about, could have an impact on how well the vaccine works. And right now there's studies going on in the United States to look at vaccine failures. We have a number of people who have actually been vaccinated, both doses, and still came down with infection. Remember, that shouldn't be a major concern in the sense is the vaccine not working, because we always said it was 90 to 95% effective. So if you're vaccinating millions and millions and millions of people, even 1 or 2% who might still get infected, which is a very, very different number than 100%, will still result in vaccine failures. And so we're looking at that very, very carefully right now to make sure that the variants are not part of that picture, and that trying to understand just, can we better predict who might actually develop infection even though they've been vaccinated.
So one of the things that you talked earlier, there's two things I want to come back to, but the first one is distinguishing side effects from adverse reactions versus a typical normal response to a vaccination. Because I think out in the community, those are misconstrued by the public, meaning I've heard many stories about, oh, watch out for the second one, it's going to get you. And I'm like, well, that's supposed to happen.
Yeah.
If you could just distinguish for us, what's a true side effect versus a normal response to a vaccine?
Yes. Well, there are several different kinds of reactions to the vaccine that we would normally expect. The first one is just when you first get the vaccine. What is your reaction to that? And that's why you're asked to wait for 15 minutes. About 1 per million population will develop an allergic reaction to it, much like if you have a food allergy and you develop a severe reaction. And that's why we always have on hand these EpiPens, which basically epinephrine can, when injected into someone who may be beginning to experience that, causes an immediate reversal. So this is not a big challenge. No one who has had one of these 1 in a million kinds of reactions have had any life-threatening or serious illness at all with it. But it's something you want to be careful about and watch to make sure. Then you may find over the course of the first 24 to 72 hours, some people have some fatigue, they'll have a headache, and even in some rare instances, they may develop a rash around the location where you were vaccinated, with some of it actually spreading a bit over your body. You may also see in some cases individuals who will experience migraine headaches with it if they've had migraines before. But these are all very rare events, and none of them what we'd even consider close to life-threatening or dangerous issues that require hospitalization. So from that perspective, these are really quite safe vaccines in terms of the mRNA vaccines. We're still looking carefully at these adeno vaccines, the Johnson & Johnson and the AstraZeneca, on the issues around this thrombocytopenia and the issue of the blood clots, what's happening there. And again, these are still very rare events, but that work is still ongoing. So those would be considered immediate reactions or delayed reactions. We also have looked carefully at other health effects. For example, in pregnant women, is this vaccine safe? That was a very relevant point because of the fact that there were over 320,000 women in the United States who worked in healthcare, who as nurses and other professionals in that area, if they were pregnant, could they get the vaccine to protect themselves from getting COVID-19 itself at work? And we found surely the data supports very much that these are very safe vaccines for pregnant women. And today they're routinely recommended that they get vaccinated. So we just haven't seen the kinds of reactions that would challenge us to say that these are fatal reactions that are going to occur right after the administration of the vaccine. The ones we're still studying, as I pointed out, are the ones that involve the blood clots and what may happen there. And you will have more data on those with the J&J and the AstraZeneca vaccine as time goes on.
Thank you. And one of the things that I was wondering about with those reactions is, and we talked about vaccines that have 1 dose versus 2 doses. And some of the things that we talk about in the rural communities is sometimes it's getting that back out to get the second dose in the appropriate time frame. What happens if you don't get the second dose or you have to delay it? Is there an issue with the efficacy of the
Yeah. Well, clearly, getting the 2 doses is very helpful in terms of your immune response. As I pointed out earlier, we know that you can get up to 80% protection after a single dose of the 2-dose vaccine, and that it climbs over 90% with obviously more durability with the 2 doses. But some countries, for example, like England and now Canada, who are in the throes of major outbreaks, did not have enough vaccine, just went with a single dose, the second dose delayed for up to 12 weeks later. Now, it's of note that when these studies were done to get these vaccines approved, they actually tried to get them approved for all the obvious reasons as soon as possible with the studies. So they picked booster dose timings of 3 and 4 weeks after the first dose, which, if you know anything about boosting, that's actually a very, very quick timeline to do that. If it works, it's great. If it doesn't work, though, it doesn't mean that it wouldn't work if you boosted at 6 or 8 weeks. Think of yourself right now. Everybody went out and planted all their bulbs today for flowers. You wouldn't count on going out and picking flowers, 2 days from now. And that's what the immune system's like. It takes a while for the system to actually rev up and to be primed in a way that when you get the second dose, it really provides for the maximum impact of the vaccine. So I give you all this background because we know you can delay that second dose for some time, and it doesn't cause you any problems whatsoever. Some people would suggest that delaying it, at all might give variants a better chance to work because the antibody is not as strong as it is after second doses. But there's no evidence of that in England, where they've expensively using 1 dose for now and not doing the second dose to 12 weeks. Some viral immunologists, people who study the immune response from viruses, would tell you that there may be an advantage to getting your second dose later, because then you will have had your immune system's maturation. So when you get the booster dose, just like we do with so many vaccines, how many vaccines are you aware of? We routinely get the booster dose after 3 weeks. Not many. And so I think that at this point, try to stay with the schedule if you can. But if you don't get your second dose for a 2-dose vaccine until 8 weeks or more, it probably is not of any consequence, except it may give you a better response. And that's surely what the Brits have shown us.
What about the idea of mixing, like if I get a Moderna the first time and I can't find access to a second Moderna, can I get the Pfizer?
At this point, it's recommended you not do that until we have more data to support that, in fact, you get the same boosting response out of a different vaccine for a second dose than from the first dose. I think in the end, we're going to show that it makes very little difference. But for now, it's recommended you try to get that same dose. If you don't know what it is, no record available, you can't remember, then people will say pick whatever one's available. And no one is told not to get vaccinated. But I think over time that will become the norm. But for now, it is try to stick with the one you have.
Okay. And do you think we'll see a boost, or not variants, but other 2 vaccines that require right now 1?
Do I think I'll see you broke up a little bit there. Do you think I'll see a boost in?
Do you think we'll see a booster shot for the other 2 vaccines?
We may have a booster shot for all of them. And a booster meaning that it's really not just to take your immune system for the same antigen up a little higher, but it's more that if we do see these variants develop that may actually challenge the immune protection from these vaccines, that it is like the annual flu shot, where the shot I get next year may be slightly different than the one I got this year. So you don't really call it a boost, you actually is a new dose. And that could happen here, we just don't know yet.
Okay, thank you. Let me switch gears a little bit. I'm a father. I have 2 kids, one in high school and one in middle school. And we have recently had our children go back to school full time, 5 days a week. As a parent who is vaccinated, whose wife is vaccinated, because we're both healthcare workers, there is concern that the kids are going back to school without vaccine. Can you talk about the risk with that decision? And then talk a little bit about the timeline, potential timeline for a vaccine for kids under the age of, I think one allows 16 and above, but the rest are 18 and after 18 and older.
Well, this is a topic near and dear to the hearts of many of us. I, as a grandfather of 5 young children, have an intense interest in this topic also. So Trust me on that. Let me just take a step back and say that from the very earliest days of the pandemic right up until recently, there was only very limited evidence that younger children were efficient transmitters of the virus themselves, or that they didn't get as often as seriously ill as anyone else when they did get infected. There have been studies done showing that, in fact, in school settings, that it was quite safe relative for these younger kids, K through 8th grade. Older kids are acting more like adults all the time, in large part because of their social behavior and just mixing and matching so much with all the activities they do. So based on that, actually, I was one of those who were supportive of bringing kids back to school in that K through 8th grade in particular. Well, things have changed. This B.1.1.7 variant that I talked about that emerged in the United Kingdom and has really wreaked havoc in Europe is one that is at least 50 to 100% more infectious and at least 50 to 60% more likely to cause severe illness. And it also readily infects kids such in a way that they not only get infected, but they transmit the virus and transmit it readily. That's one of the things we're seeing fueling this new surge of cases in the upper Midwest, in Michigan and Minnesota right now. In our state of Minnesota, in the last 2 weeks, we've had 790 schools with activity with COVID-19. Now, we don't have sequenced in all of those, but the vast majority appear to be due to B.1.1.7, the one I just talked about. The challenge we have right now is that with this so highly infectious in kids, it's spreading quickly in the schools. And of those 790 schools I talked about, a large number of them are having outbreaks, which means that you now have transmission in such a way that it spreads through the school, and you obviously are concerned about protecting students and teachers, who most of them by now are vaccinated, students not. And you have to raise the question, what do I do? Well, in many instances, you see a very rapid reduction in the number of students in school because they're at home in quarantine. On average, we'll often see up to 80 kids per high school student exposed for one child bringing COVID-19 in the high school years. Those kids then have to go home and stay home for the duration of the quarantine. The same thing is true with younger kids. There we're seeing a slightly lower percentage of younger kids who, in terms of overall classroom, that have to stay home, but it's still in the 30 to 40 range as opposed to the higher number with the high school. And so when you put this all together and you realize that this virus is causing more severe disease, and we're seeing that right now in our pediatric intensive care units, and the fact that school is just about done. For many school districts right now, particularly if they're in hybrid learning, they only have 15 to 20 days left of school. In terms of the annual school year. If you're not in hybrid learning, just regular, you may have more. But at this point, I think if you have B.1.1.7 that is actually circulating in your area, it's one of where I would not want to have schools open or coming to in-classroom learning. I think the evidence is clear and compelling. This virus is so infectious. And so I've just come back to, this is not a standard recommendation, but I think you're seeing here in Minnesota and Michigan and places like that, Ontario, once this is in the schools, it's a real challenge. And since this is now causing serious illness in students, I really believe as long as there's evidence that public health has that B.1.1.7 is causing these outbreaks, I think we really need to just get through the school year, get into summer, prepare for next school year. As we talked about earlier, I'm convinced we're going to have vaccines at least for 10 years of age and older, and it won't be long after that we're going to have vaccines down all the way to 6 months of age and up. And I think that's when we can really fundamentally change the picture of this virus in our communities and what it's going to do.
Thank you. And I feel the exact same way, but I'm just holding my breath for the next couple of weeks until the school year is out for the kids. But
I think one of the things that also I should add here is because it takes a while to get these viruses sequenced. When we're talking about sequencing a virus, we're actually talking about determining all of its genetic material, et cetera, so that we can understand, is this a B.1.1.7, one that's much more infectious and one that is more likely to cause serious illness. Here we're recommending that don't even wait for sequencing. If you have evidence that B117 is in your area and you're watching really rapid transmission in your schools, I can all but guarantee you it's B117. It's so different. If you were to survey 40 school nurses in Minnesota right now and say, what's the difference between B117 and all the previous strains you dealt with, they'd say everything, everything. We've talked to them. It's just much, much more transmissible. And so that's why, we all want kids in school. I want them in school. But this is one where I think from a safety standpoint and what the role is of these kids transmitting once they get infected to their parents. Right now, our highest risk age groups for intensive care medicine requirement is actually the 30 to 39-year-olds and 40 to 49-year-olds. And much of that is related to exposure to younger kids.
So given that we have this B117 variant that's really infectious, and that obviously the vaccines right now are not 100%. So you have this idea that, okay, I'm vaccinated, and maybe there's a mindset now that because I'm vaccinated, I don't need to be as careful because I have the vaccine. And I've seen this in my community where we're out and about without masks on, even though it's a public event that I don't know who's been vaccinated or not. Can you talk a little bit about the risk of sort of letting your guard down after you get the vaccination, especially when there's new variants around?
That's really an important question, and thank you. I think you framed it really very, very well. As I said earlier, no one wants to be the person to die 3 days before they're scheduled to get their COVID vaccine. And what we're seeing happen right now is people are done with this pandemic. They just don't want it anymore. Well, this virus doesn't care what you want. It's like virus gravity. It's going to act if it's there. And so I think the challenge we have is, number one, is that B117 is very effectively handled by the vaccine. So we don't have that problem. What we have to do is wait it out. We just don't have enough vaccine. We talk about vaccinating 3 million people a day in this country, but in reality, it's only about 1.5 million. Because remember, half that dosage is going to people getting a second dose. So it's not brand new people. And it's going to take us a while. If you look right now in states like Minnesota and Michigan, Michigan has 39% of its residents vaccinated with 1 dose, 25 with 2. Minnesota's 37 and 25. And yet we're both seeing major outbreaks. And it just points out that even with that much vaccination and with all the people who previously been infected who have some immunity to the virus, there's still enough people to get infected to cause this major increase. Today, Michigan maxed out at the same numbers they had hospitalized, et cetera, as they did in their biggest and worst days of the peak of last fall. And so you get a sense, you can't say, well, the vaccinations are going to stop this. I mean, right now, surely they're having a major benefit in terms of fighting this virus, but it's not enough in of itself to say that it's going to be all over with. And so what we need is just to keep getting vaccinated, getting more people vaccinated, and then protecting ourselves from getting infected, which means right now, don't be in crowded places. Don't do the things that you wouldn't have done 3 or 4 months ago. Don't do them. And I know that's hard to hear, but we're so close. We're so close to getting so many people vaccinated. Then that also raises, though, that second point of that so close has to be really so close. And what I mean by that is I am concerned we're seeing a growing number of people who's decided, I'm not going to get the vaccine after all. And if we see a sizable number of people in the public who don't get vaccinated, we're going to continue to see this transmission ongoing, which is going to delay any possibility we have for kind of getting to that new normal. I mean, I've already set my sights. I and my partner just bought very expensive but wonderful tickets for a major concert on August 31st. And I'm counting on, by that time, we're going to be much more back to normal. But that's going to mean people are going to have to get vaccinated. And so I hope I don't have to turn those tickets in because it's not yet safe to go out. So I can't just say it enough. Just keep doing what you're doing, you have been doing to protect yourself. And if you don't, I'm afraid you'll pay the price. This is a bad virus.
So if it's a good idea to continue wearing masks, there's been a lot of controversy about what type of mask to wear. Can you talk a little bit about the different types of masks that maybe the public could utilize that's going to give them the best protection?
Well, first of all, remember that the primary way we're all getting infected is through breathing in the virus. It's not from hygiene theater, as we call it, related transmission, i.e. in the environment. And finally, even CDC came out last week and basically said it's not from the environment. So for all of you who've been wiping down all your goods coming into the home or et cetera, you don't need to do that anymore at all. Still wash your hands. We have a number of other infectious diseases we're concerned about, but don't feel like you have to wipe those things down. So I'm breathing it in, and we now know very clearly that this is what we call an airborne virus, meaning the very, very tiny air particles, not just the big cough bubbles that come out, that fall down within 6 feet, but it's these things that come out of our mouth and our nose that we don't even have to be coughing. It's like cigarette smoke. How many times have you been walking down a street or even in a room where someone's smoking and you don't even see them at first, you just know it's there, and then you look around to finally find them? That's what an aerosol is. And so we need to have that kind of protection. Frankly, the only reliable protection against an aerosol is what we call an N95 respirator. It's one that healthcare workers use often, a lot of industrial applications for it to try to keep out toxic gases or dust or whatever. And the way an N95 works, it has a very, very tight face fit. Think of it as a swim goggle. You don't leak in a swim goggle through the glass, you leak through the edges. And so you want that tight face fit. So that also means men with beards, nope, doesn't work. But then in addition, the material that's over your face is a special pored material that actually has pore sizes bigger than the viruses themselves, but that allows the air to come in and out. But you say, so then what good is that? Well, it has an electrostatic charge. So just like a good filter, it'll catch the virus coming through. So one, you can still breathe, but two, the virus doesn't get through. Those are the ones that are most effective. If you think of a 1 nanometer particle, very, very small aerosol particle, that N95 will let pass less than 1% in or 1% out. So if I breathe it out, less than 1% of those will escape. If I breathe in, less than 1% will come in from the outside. If I go to a surgical mask, a medical mask as some people call it, those don't have a tight face fit and they don't have the same breathability that you see in the sense of an N95. There we can often see 35 or 40% in passage of 1 nanometer particles in and out. It doesn't reduce it that, in more than that. Now remember, it's also time and concentration. So if I'm in a room that has very, very low levels of virus, I might still get infected as somebody who's in there in a room with a much higher level if I'm in that room much longer. So it's a combination of time and how much is in the air. If you go to a face cloth covering, just a face cloth covering, as a lot of people have today, or that you've seen people making these masks, they often leak 60 to 70% of the time, both in and out. So it still reduces your risk from 100% in and out. But know again that time is an element that is very critical here in the concentration in the air. Think of it more like a seatbelt. No one believes for certain that a seatbelt all by itself will save you in a crash. It's the airbags, collapsible body, it's the fractured window that won't cut you because it all goes to shards. That type of thing is important, but a seatbelt is still critical. So one of these kinds of face coverings or even a surgical mask is more like that of like a seatbelt. So don't count on that to be the overall protection. And then the final one is the gaiter. And research has shown that that one leaks over 80% both in and out. So if I had my druthers, obviously I want an N95. I want to also limit myself in terms of where I might go with large crowds. As soon as you break the integrity of that respiratory protection device, whether it's an N95 or a cloth, virus comes in and out readily. So people who wear them to go eat and they constantly lift them up and move them down, that's kind of like fixing 3 of the 5 screen doors in your submarine. It's not all that effective. And so I would say right now, that's why I think we continue to tell people to mask up but we also want them to understand distancing remains their most important piece. And then being outdoors. Outdoors air very rapidly disseminates the virus and makes for really overall the safest environment in total.
Is there a good way to clean a mask? If you have a cloth mask or another mask, is there a better way to clean it?
Well, N95s, first of all, is again a very different. We now know that if you basically let that respirator sit for 5 days, any virus activity on it will basically be destroyed. It'll be gone. So unfortunately, in the day of shortage with N95s, we had a lot of healthcare workers that had 5 or 6 of these, that when they got done, they'd put it in a brown paper sack, label it, put it on the shelf in their work area, and then after 5 days, use that one after they keep rotating through all of them. And that way they could use them over and over again. Now that's hard to do, and we need a much better supply of N95 respirators. As far as the other ones, you can, surgical masks come and go. You can get those relatively easily. They're very difficult to wash because they're typically a material made with some kind of a combination of plastic, et cetera. And then, of course, the face cloth coverings you can wash any number of ways, and that won't hurt them at all.
I live in an area where there's a lot of outdoor sports that they're still trying to do, and the kids, obviously, we're trying to enforce mask wearing. I know a lot of companies have come out with sport masks to help with that. Are they really any different than other types of masks to allow kids to participate in sports?
They're really not. And
Okay.
they're limited in what they can do. The benefit you get from wearing that, which there is some, is probably overtaken by the benefit you get from being outside, and if you're not too close to people.
Okay.
We still see outbreaks, or we see increased cases of outdoor activity. A good one is I've seen several recent pieces where we've had baseball teams become infected, and it appears they're all in the same dugout. And even though it's outside in that dugout area, the air is not moving much. And so people get infected there. Indoors, one of the most efficient ways to transmit the virus is hockey rinks. We have seen many, many outbreaks right here in Minnesota with indoor hockey. And the reason for that is because that cold air that comes from the ice comes up along the boards and the glass. And then at that point, based on the ventilation of the building, you have warm air. Well, if anybody's ever seen morning fog, ground fog, you see how it just goes to a certain level and cuts off. That's a temperature differential, where it's cooler, where it's warmer. And what we see with hockey is the air doesn't move much out of inside that rink. The boards and glass hold it in, and all you need is one skater in there, really puffing and huffing, and you just make that a virus soup. And so we've had a number of outbreaks in hockey, particularly in indoor arenas.
That's unfortunate because I'm a Hurricanes fan and I have season tickets, and we had to postpone them this year for that reason. So I guess
And as you probably have seen also, the Vancouver Canucks have not played for several weeks.
Yes.
Because of an outbreak they have in their team of what's called P1, the Brazilian variant, which is very, very serious. And so Vancouver right now has been an area that's been really heavily hit with that variant.
I think it's important that we start watching what the sports teams are doing. If I think about professional athletes and things like that, they have a lot of money to spend on testing, on precautions, and yet they're still being affected by the virus. I think as a community, we need to pay attention to that because we don't have that same number of resources dedicated
Yes.
to just detection and vaccination and those things. So I think it's an important piece to think about. If they're struggling at that level, we're probably struggling at our level as well.
And I actually happen to sit on the NFL diagnostic testing committee, which is the group overseeing the programs for the NFL. And I have to tell you, it's been an extensive effort with testing every day, and different kinds of tests, a great deal of activity around tracing when people have exposure to someone else, so that if someone does become infected, they can tell right away who the contacts were, wearing little devices that pick up distance and time from somebody else wearing a device. How to work with your family. A number of the players actually originally got infected at home, not thinking about how the home was different than at work, but more so that, the maid came in or neighbors came over and they didn't realize that need for that bubble. And so it's been an education process, even for major league sports. But as you pointed out, they've had the resources to be able to really do this. And we've learned a great deal from the testing that they've done and how well these tests work and what they can tell us.
I want to switch gears just a little bit because early on, you hinted at, we talked about education as being affected by this, but I think there's a lot of other, what I'll call secondary drivers of health that have been affected by COVID-19 and the SARS virus. For example, I'm in education, obviously at UNC Pembroke, we do a lot of education, and we're beginning to see the effects of changing learning, a rapid switch in learning at the collegiate level, as well as at the high school level and younger, trying to get them to continue to move through their education. There's concern about the long-term impacts of that. I think there's concern about the long-term impacts on mental health, being that we're now dealing with a pandemic now for nearly a year, or I think it actually is a year now. Can you just talk about some of the secondary consequences that we're going to be dealing with for a long time post-COVID, meaning the virus might be under control, but its effects are long-lasting?
Yeah, I surely am not a primary expert in this area, other than, as I pointed out, I'm the grandfather of 5 grandchildren, but also I have consulted a lot with other experts. And in my podcast 2 weeks ago, I do this weekly podcast, as we discussed, and actually Teresa Thayer Sawyer, who is, can we cut this out? Teresa Thayer Schneider. And she is a school superintendent from upstate New York who has written several wonderful pieces about the kids and what might happen here. And she really warned all of us to not grip too tightly here and think that this is a crisis. That what we're going to need to do is help our kids express what did they learn, what did they feel, what did they go through this past year. That's what's going to be really very critical. And we don't want to at all, somehow wish the children into a very bad place. What really happened? And we know that some kids missed meals, some people lost loved ones, some kids had to give up pets that they had because they couldn't financially keep them. Some kids went through a lot of things. And her whole message has been, when we come back to school, we need to tell those stories. We need to work with the students, because what they missed was not the classroom per se. They didn't miss the tests. They didn't miss the homework. They missed the teachers. They missed the getting together. And I think her message has been really very clear how important that is. And that we are going to probably do a lot better than people believe we are. Now, I don't want to minimize for a minute that also I've heard from a lot of parents who said, you know what? Having my kids home turned out to be one of the best years of their entire school year. Why? Because they weren't bullied. Why? Because basically they always were an introvert and they always felt out of place every day coming home. And now they don't want to go back to school. And so I think it's going to cut both ways. Surely it's going to be a challenge in terms of helping students who have suffered because of not being in schools, but also listening to children who have benefited from this, feeling like they've actually had some advantage. And how do we best understand that and support that going forward?
And while you mentioned, I think that's fantastic. And I want to just give a plug to your COVID-19 podcast. If the listeners are looking for additional information, which takes the time to go into really a lot of depth across a lot of topics around COVID-19, I would recommend tapping into what's called the CID-RAP COVID-19 podcast with Dr. Osterholm. And I'm just going to save the email address, and hopefully our editors will put it up on the screen. But it is CIDRAP.UMN.EDU /COVID-19 /podcast webinars. I have actually spent some time listening to them, and they have been really informative. And I would suggest that if you're looking for more information, this is a great place to go. So I just want to give you that shout out, because I really appreciate those efforts.
Well, I appreciate you mentioning it. Thank you.
One of the things that you recently talked about are winnable moments. I want you to put on your future hat. You're looking at upcoming winnable moments that you see on the horizon for us.
Well, let me give you an example from the podcast last week. we always have an act of kindness in our podcast. We tell a story about things that we can do to, get through this pandemic with kindness, with understanding, with patience. And the winnable moment here was a veterinarian whose primary practice is to go to people's homes and assist with euthanasia of loved and beloved pets in their older age. A hard thing to do, but what an incredible gift to those who love their pets. And as somebody who is a very, very dyed-in-the-wool dog lover, I've shed far too many tears over that dog that unfortunately couldn't be with us any longer because of health issues. Anyway, so she's at this woman's home assisting with her cat. Her family had moved away, and her cat was her life. And now she had to basically help her say goodbye. As she went to walk out the door, the woman actually put her hand on the veterinarian's shoulder and said, I suppose we can't, do anything else, can we, right now? Can't hug, which has been a way we've helped each other for so long as a society. She gets to her car and she realizes this just isn't right. And she turns around and yells at the woman at the front door and said, are you vaccinated? And the woman said, I am. And the veterinarian said, I am too. And they rushed and met each other and held each other so tight for so long. And it was what they both needed and both wanted. And it was a winnable moment because why? They were vaccinated. That's the kinds of things we have to find. How can we help? How can we make it possible to do things for helping each other? Every week on these acts of kindness, I can't tell you how many times we have winnable moments where, in fact, people do wonderful things for other people because of the pandemic. And these vaccines are every bit winnable moments. As more we get vaccinated, more and more we're going to see we can do so many more things safely with feeling that and confidence that it's going to be okay.
Yeah, I'll just share. We actually had one today. I had a meeting with two other colleagues, and we asked the question, are you vaccinated? Same thing, are you vaccinated? And we said yes. And we had to sit down and take our masks off, and we still stayed apart. But we actually had a conversation looking at the whole face for the first time. And just, it was smiles. For the first 5 minutes, it was just delightful that we could actually engage at a human level again. And that was so important.
That's a great example, and that's what we can do. We can do that more and more.
That is why I do it, so I can get those interactions. And I really look forward to the time that we can do that with our students and interact with them face to face again here on campus. Let's talk a little bit about, I get vaccinated, and I'm promoting it. What are some things I can do, like we talked about? What are some things I still shouldn't do? We talked earlier about still wear a mask, but there are other things that we need to think about from that perspective of there are vaccinated folks and there are unvaccinated folks. What should we be doing?
Well, I think we're at a period of some real confusion and kind of, I might say, unnatural thinking. And what I mean by that is we're coming off this year of this pandemic where, we've all been feeling this desire to get back together, but the fear of doing that. Now, not everyone may be feeling like that. Some may say this is crazy. We should all be together anyway. And so I think that what we're trying to do is find that new normal. What is it that we can do and all feel comfortable with? The CDC put out recommendations about 2 weeks ago that said, okay, it's now safe to fly if you're vaccinated, but don't fly right now, which, people looked at and said, what? That doesn't make any sense. And it actually does with what they're saying. Imagine I get my vaccine, 95% effective. Imagine I'm a firefighter and I have a fireproof suit that will protect me 90 to 95% of the time. Wow, what a benefit over nothing at all. But I don't go walking into 10-foot walls of fire just willingly with my fire suit on. I try to avoid that. Well, what the CDC was saying right now with B117 in particular, in some of the areas of the world where these viruses are really transmitting largely and loudly, do I want to be on an airplane with people and say, why don't you wait a little while until more people get vaccinated? until we can be more certain that you're not going to be walking into a 10-foot wall of fire. So it doesn't mean your vaccine is not working. It doesn't mean your vaccine is not going to help you. So I think that we'll see over time, if we can get more and more people vaccinated, at least in this country in particular, it's going to be safer and safer for everybody. So when you get vaccinated, you not only protect yourself, but you protect your loved ones, and you actually help protect the community. So that's what we're looking for, is let's drive this virus level down to as low as we possibly can. So, if I do encounter the virus, I got a 95% chance of not getting infected, but I'd rather take that chance with fewer and fewer opportunities to get infected by just driving the level down in the community.
So is there a magic number? I think there's this idea of herd immunity. We've talked about, everybody should get vaccinated, help your neighbor out. What is herd immunity? How does that work?
Yeah. Well, herd immunity actually comes from the area that you might think, based on what it sounds like. It comes from veterinary medicine. And it was really all about if you protect a certain number of a group, that it's like rods in a virus reaction. You slow things way, way down. So for example, if you have in measles, a disease for which is highly infectious, respiratory spread, we often say that you need 94 to 96% of the people to be protected in that population for measles not to spread, because it's that infectious. You'll find somebody who is not infected in your environment if it's not that level. Now, that can be deceiving, because you can have 100% of people vaccinated in a large area, but a small pocket of people where nobody's vaccinated and may come out to be 96% overall, but it's not. It's 100% versus, 10 or 15% in a segment of the population. That's how we have measles outbreaks that continue. So with this virus, we're still trying to figure out at what level do we have to have people immune to it. That means it would slow transmission way down. Herd immunity doesn't mean it stops it. It just means, think of it this way. The next time you're on a plane and you hear the pilot say, okay, we're beginning our ascent into Reagan National Airport, you're still 25 minutes out. Okay, what it means you're losing altitude? Well, it means that once we hit this herd immunity level, transmission slows down and you don't have as great a chance of getting infected. With this virus right now, we just don't know what herd immunity is. And what I mean by that is with B117, as I pointed out earlier, it may be 50 to 100% more infectious. We could be talking about levels right now that are not that far away from measles-related herd immunity, which means I don't think we're going to get there anytime soon, particularly if we have a large number of people who do not want to get vaccinated. We also have to worry about the concept of waning immunity. We've talked about might we need a booster dose? Well, we're going to find that out too, because if people can get infected after having been vaccinated, but then being 2, 3, 4 years later, which we don't know yet, maybe it won't be, that's going to play into it. So right now, all I can say is the more people we get vaccinated, the better off we all are. And that's what we want to do. And whether we hit that magical herd immunity, I don't know.
I hope we find it. I
do
think you're
too.
right. I think that number is unknown, and I'm just watching the vaccination numbers go up, and hopefully we hit that target at some point.
There you go. Yeah.
Well, we're coming to the end of our discussion. I was wondering if there's anything that we didn't talk about that you might want to end with in terms of the virus or dispelling some myths. I think you've done a great job of dispelling a lot of the myths that are out there about the virus. Is there anything else that we could cover in our last few minutes together that you think about?
Well, I think that one of the things that I urge the students to consider, and being in higher ed, I had an experience this past year that I someday probably should write up for an educational journal. Last spring, when the pandemic began, our group at CIDRAP were one of the first in the world to acknowledge there's a pandemic. In fact, on January 20th, over a year ago, I put out an article from our group saying this was going to be a global pandemic. Well, we were just starting our spring semester at the University of Minnesota on the very day that I put that out and said, we're going to have a pandemic. Well, of course, most students looked at me like, what? And I had 28 students in class learning in an advanced infectious disease class. By the first week of March, as you know, we were distant learning like everybody else in the country. And at that point, we had our weekly class online, Zoom. And what happened was it became almost a support group getting through COVID-19 day after day. So when the end of the semester came, we decided, I said, if you want to get together, I'll still do it on Mondays for an hour. And ever since a year ago, we've only missed 2 Mondays since that time.
Wow.
And we still do every Monday with this class, well after the class is long gone, well after the students have graduated and gone of where they are. Now it's jokingly referred to as Mondays with Mike. And I swear to God, if I had to pay in therapy bills for what this group afforded me in terms of support and understanding, they could all go out and have a wonderful evening dinner on me. And so I think that's an example of what were the things we've learned during this pandemic. Well, we learned, the teacher-student relationship is critical, but what's really even more critical is we all get through this together. And I think there are just so many lessons learned that we don't want to leave by the wayside. We want to understand them. We want to know, what did this kind of education do for us? Did it make us more appreciative of in-class performance? What did it teach us about how we could improve on that? Can we offer advantages for distance learning that we hadn't thought about before that now we are forced to have to do? So I think it would be a terrible, terrible thing to waste a crisis. We should take every advantage to learn what we can from what we went through, whether it be a class, a department, a college, a university, whatever. And I think that, to me, will be one of the silver linings out of otherwise a very, very dark cloud that we've experienced for the last year plus.
Thank you for that. And I would agree with you that I think we've learned a lot of lessons along the way. I hope there's an opportunity to capture all the lessons that we did learn, because my fear is that we'll forget and go back to the way things used to be. But I really appreciate our conversation tonight. Thank you for taking the time.
Thank you.
It was
thank you,
wonderful.
Todd. It was great. I really appreciate the time with you. It was really wonderful. Thank you.
And I hope to see you on campus at some point, face to face,
so.
and we can do another talk of after COVID.
You got a date. You got a date there, okay? I'm
right.
willing. I'm willing. Okay.
Yep. Thank you again, and I
Thank
appreciate
you.
your time.
Take care. Thank you.